like do that?
Yeah, we are definitely,
all set.
we take a bunch of people, but we have like formal games. But I'm trying to push more boys. They definitely come talk to me.
You're all set, Elise.
In the show. All right, welcome everybody. We'll go ahead and get started. We will start with introductions. I'll start and I will go to my left around the room and then we'll do online after we're finished with in the room. We do not have quorum tonight, just FYI. And we still have not been able to get the new members approved, except for, wait, you told me one person who was approved?
Deputy Barber.
Oh, okay,
The
okay.
last person we sent up is the only one. I did talk to the legislature. I specifically talked to the clerk today. We have given them all the names. They are clear. They're going to put it through. The 18th, Health and Human Services will be the committee meeting, and then they should, the 19th, the next day, be on the full legislature committee. So hopefully, within a couple of weeks' time, we'll have them. We will call on the 20th to make sure that that has all happened. And then you'll all just need to get sworn in before the first meeting. If you can't, Karan is a notary, so she can swear into the meeting.
That's great. And we don't have any voting to do today, except we would have voted on the minutes. So in January, you'll be voting on 3 months of minutes. And we will not have an executive session at the end. We're going to introduce a slate, but we don't need to do it in executive session because we're not voting on anything today. So there won't be much discussion. Okay. All right. So my name is Elise Schweitzer. I am the chair of the board.
I'm Howard Reed, a prospective member, and I was worried that it was something about me that was holding up. And I'm reassured that you're saying that, no, I don't have to worry about it.
We desperately want all of you to be a part, as you can tell, because we can't get to quorum without you. So it's on us and our apologies. So thank you for being patient with us.
Hi, I'm Nicole Zulu, Director of Health Planning and Human Service Coalition, and hopefully prospective member as well.
I am Ross Milne. I'm a new public health graduate fellow working on the LGU opioid settlement program. So I'm just here to present.
Great. Sally McGallo-Cheney. I'm on the Community Services Board, and I'm also on the Developmental Disabilities.
I'm Dr. Elena Zath. I'm a clinical psychologist and I work at Guthrie. And I'm integrated in their primary care family medicine.
My name's Carrie Stock. I'm the Director of Specialty Services for the Downtown City Harbor location.
I'm Frank Krupa, the commissioner.
Travis Winter, board member.
Jessica Connor, clinical psychologist, board member, and mental health subcommittee member.
Sheila McHenry, board member, as well as a member of the DD subcommittee.
Hi, I'm Dr. Anna Tamas. I'm a clinical psychologist and a prospective board member.
Hi, I'm Jan Lynch, and I'm a member here at the Community Service Board.
Yes, different board member.
And online, I'll go to Sean.
Good evening, everyone. I'm Sean Carney. I'm representing Guthrie along with my colleagues that are in the room. Thank you for accommodating virtually.
Thank you for coming. Deb?
Hi there, I'm Deb Mollenhoff. I'm just here at the request of Frank and Harmony. We've entered into a new partnership where the city and the county are going to be merging our initiatives around the opioid settlement money. So I'm excited to be here today and answer any questions and learn more.
Great. Khaki?
Hi, I'm Khaki Wunderlich, also practicing my patience.
And Ross.
That's me.
That's awesome.
Sorry, you're there too. Okay. All right. So in terms of additions or deletions, the agenda, the only addition to the agenda is that we have a presentation from the nominating committee that we'll do at the end of the meeting to introduce a new slate of candidates. So we're not going to be approving minutes tonight. Privilege of the floor. Any questions or comments from board or guests?
Just one, I don't know whether this is board correspondence or announcements, but one of our earlier conversations is around the adapted aquatics for children with disabilities. I ran into an old colleague today who's actually providing lessons at the YMCA. Joni Groom, if you remember Joni Groom, Retired Youth Bureau is actually kind of, I guess, managing that program. So I went on the Y website to get a little bit more information. I didn't get very much. There is a class. It appears to be in the evening, 5:30 to 6:30 every Tuesday. But I did email Joni to get more information. So I know that was a topic. I think Jessica brought that up, and I know in the DD subcommittee, it's also been a topic. So I hope to get more information, and once I do, I'll bring it to the board.
So I did meet with Joni as well as her supervisor and her supervisor and found 3 different grant opportunities that they're going to be pursuing to hopefully get that supported swim class funded. So they've got 3 different grants that's staggered with staggered due dates. So hopefully it should be fine. Great. Any other questions or comments? Correspondence or announcements?
Do have a quorum now.
Great. We'll go back and we'll do minutes then. So we are looking at minutes from both October and November. So let's vote on them. I guess we can vote on them together as long as there's no changes. If there's changes, we'll probably have to vote on them separately. I make a motion to approve the minutes for October 2023 and November 2023. Okay, second. Yeah. All right, great. All in favor of approving the minutes as written? Say aye. Raise your hand. Great. Okay, minutes are approved. We are caught up with minutes. Okay, chair's report. I don't have much to report except to say that this is my last meeting on this board. And it has been a true privilege serving not only on this board, but also in all of the various subcommittees over the years. I think after I go off this board, it will be the first time and there may have been a year or 2 gap here or there, but for the most part, I've been connected to one committee or the other since 1997. So it'll have been a very long time. It'll be weird not to come to this 6th floor giant table anymore.
You're gonna miss the table.
I'm gonna miss the weird table and chairs. So thank you very much for allowing me to serve on this board with all of you. It's been a great pleasure. That's my report.
You did a great job, Elise.
Yes,
Thank
much
you.
appreciated.
Thank you very much.
Created a very positive influence on our board. I appreciate it.
Thanks, Stu. Appreciate that. Great. Okay, so we have some guests tonight from the Guthrie Medical Group and the City Harbor Guthrie Medical Group. We're going to hear information about implementing the Zero Suicide Initiative. So I will let them take it away. Thank you for coming.
Right, I think we're kind of gonna share a little bit, and Sean's gonna kick it off here for us. Hopefully be able to pull up some slides.
Share screen. Okay, can everyone see that?
Yes.
Great. Okay. Well, thank you very much, first and foremost, for the opportunity to highlight for all of you our work with the Zero Suicide Initiative. Really, our journey began probably 5 to 8 years ago when we began to initiate our own discussions around how we can support the communities that Guthrie is in with behavioral health and with implementing really the mechanisms around our patient-centered medical home model, which we embraced a number of years ago, and then more earnestly 5 years ago started to really dig in on the community needs that we've identified around this subject. And I'll give a little bit of background on Guthrie for the benefit of everyone else that may not know us. Guthrie Medical Group specifically is a multi-specialty group practice that was founded in 1910 by Dr. Donald Guthrie. We are modeled after the Mayo Clinic, where Dr. Guthrie had completed his residency. We have more than 365 primary care and specialty physicians, 300 advanced practice practitioners, and more than 1 million patient visits each year in 22 communities. You know us well in Tompkins County, primarily because of our work at the Hanshaw Road office, and then also our City Harbor location that opened a couple of years ago. Guthrie currently has 5 hospital facilities and will shortly, by February 1st of next year, have 6 hospital facilities. The majority of our work after our acquisition of Our Lady of Lourdes Memorial Hospital in the Binghamton community will be centered in New York State. We have 2 inpatient behavioral health units in our system as well, one at Robert Packer Hospital, and then our secondary unit at Cortland Medical Center. And you can kind of see the acquisition stage of Guthrie over the past several years as we've continued to grow and expand and bring services to our community. In 2023, our Ithaca-based offices supported more than 111,000 ambulatory patients seen, and that's between our 2 offices at City Harbor and at Hanshaw Road. We start to think about how we supported zero suicide. So initially worked through our inpatient facility at Cortland, and began to have some conversations with Scott and the whole Sophie Fund, and the zero suicide model was introduced to us. When we take a look at that model, we really see that what Guthrie has been doing in this space for a number of years is very complementary. So it was an excellent fit for us and continues to be an excellent fit for us as we delve deeper into how to implement the zero suicide model, especially as it relates to our primary care practices. So to give you a little bit more background, really the body of knowledge and work began with pursuing our patient-centered medical home recognition, and the encouragement by reaching that recognition to really report on standardized measures. And you can see here just some of the behavioral health measures that are a part of that journey. And specifically, really where we look at is CMS number 161, which is really Adult Major Depressive Disorder Suicide Risk Assessment. And that's where the work began with Guthrie, was to introduce in our primary care locations a screening tool. How do we do that? What does the screening tool look like? And how can we serve our communities where obviously, and I think I'm speaking to an audience that certainly is well versed in this matter, that major depressive disorder is the second leading cause of disability worldwide, affecting 120 million people. And we can certainly see that when studies have been conducted, that patient outcomes are improved when there's strong collaboration between the primary care provider, a case manager, and a mental health specialist. And as we move through our presentation tonight, we're going to be able to hear from Dr. Zapp firsthand about our most recent integration in primary care, and we'll ask her to make a couple of comments on her clinical practice. So as I've mentioned previously, what is our Guthrie model? As we continue to look specifically at the zero suicide model, we do see a very strong screening-based platform to come off of, and we have implemented very strongly in our primary care model evidence-based screenings. The percentage, specifically what we're tracking at Guthrie, is the percentage of members patients 12 years of age and older who are screened for clinical depression using a standardized instrument, PHQ-2, and Carrie's going to speak to that in just a minute, and then a follow-up on PHQ-9 as our two screening tools. The standard that has been mandated by New York State through patient-centered medical home is Care Coordination Standard 10, which is our behavioral and health integration practices receive credit under the patient-centered medical home, where they are able to integrate a behavioral healthcare provider care delivery system with primary care in the same practice site. And so that's really been the bulk of our work the last 18 months, is continuing to integrate specialists in our primary care model to help reach this particular standard. I would say that it's not easy to accomplish, because the evidence, as you can see here, is that you really have to merge the behavioral health service with care coordination and primary care to be considered effective in reaching the standard. And that is not a particularly easy thing to do with kind of the lack of the behavioral health specialists in our market environment. Guthrie's been very successful the last year. We had a behavioral health specialist in our Sarah location for a number of years, but we've added Dr. Zapp in the last few months, and we continue to grow this service to complement our inpatient behavioral health units, where we have a very strong provider group under the leadership of Dr. Lavin, who came to Guthrie from Lourdes originally. And so continue to make steady progress in complementing our team there. We're going to move to this slide, which Carrie's going to pick up and talk to you a little bit about our screening tools that we're implementing in the practice locations.
All right, thank you, Sean. So the PHQ-2 and PHQ-9 are the evidence-based screening tools that Guthrie strives to screen every primary care patient 12 and older at least once a year, as well as any patients coming into any of our walk-in care locations. If people aren't familiar with the tool, there's 2 questions that are initially asked. If the patient's feeling down, depressed, irritable, or hopeless, and then little interest or pleasure in doing things. If they answer positively to either question, then the clinician will go on to ask the full 9 questions. And this tool is used for screening as well as diagnosis, and it helps to monitor any ongoing interventions as well. We do these, as I said, in all of our primary care as well as our walk-in, but we do have a single EMR across all of Guthrie. So we do also encourage specialists to do this if they can see that the screening has or hasn't been done. And we just see that as another touch point, another chance to kind of intervene and interact with that patient. Okay, next slide. So you can see here some of the recommended proposed follow-up treatment actions. Of course, it would also depend on the clinician's judgment and expertise as well. So that best practice is really that warm handoff to behavioral health or counseling or other mental health services. Really excited now that we have Dr. Zaff here. I know she's going to talk hopefully a little bit later, but you know, I think having somebody embedded right in that primary care clinic where they're already getting services, where they already have that trust built with their clinician to say, hey, here's somebody that you can talk to, really reduces that stigma and really helps them to feel comfortable kind of taking that step. Obviously, there's a lot of other resources that we work with as well, the colleges, you know, members of the county, private counseling, different options. And, you know, I put the green sheet that I know was developed by kind of a lot of different groups with Sophie Fund. We really give that out to a lot of patients. We have it right in our waiting room for people. And I know we give it out a lot in our walk-in, especially. we find a lot of people that come through there that maybe don't have a primary care physician, that maybe aren't getting regular services anywhere. I did kind of get a chance to talk to one of our nurses and say, what do you do with these patients? You know, it's a busy clinic. They're seeing people every 10 minutes. It can be crowded. People are waiting. And she said, you know, the first thing I do is I just stop. I sit down with them and I say, how are you doing? How's it going? And just take a minute to check in with them and give them a little bit of attention and trying to make that connection and share with them, you know, obviously some of the resources, try to get them into primary care as well. If the primary care provider does screen, you know, something concerning on this, on the PHQ-9, a lot of times they'll schedule a very focused follow-up visit with that person. That way they can go through a collaborative treatment plan where they're really working closely with that patient and coming up with kind of shared goals and shared plans on how to address some of the things that are going on. That might include medication, referrals, things like that, ongoing kind of discussions. And then as Sean said, if there's a really more severe or acute case, we do have our inpatient behavioral health treatment centers at Cortland Medical Center as well as Robert Packard.
Thanks, Carrie. So you might be asking yourself, well, this is all great, but this is pretty standard, right? I mean, most places in primary care have adopted this standard, especially in New York State. So what's the difference with how it relates to maybe zero suicide? And that really comes along. You know, the early intervention is obviously what matters. And so when we are able to screen patients and develop a standardization to that screening, it really does early on identify patients that are at risk, and it allows us to intercede with those patients. And that has a notion that is similar to the mission of zero suicide. So the numbers are perhaps what matters in the performance, and you can see what our journey has been. So this is a system level depression screening trend report. When we began with this work in 2019, fiscal year 2019, we screened at Guthrie 61,000 patients. And that represented approximately 46% of our pediatric population, those patients above age 12, and about 69% of our adult population in family medicine and internal medicine. Those numbers were okay, weren't great. And over time, you can see that last year, we have increased our screenings now to 89,000 patients, and that represented 88.2% of our pediatric population, eligible pediatric population, and 92% of our eligible adult population. So if you are a Guthrie patient, we feel confident and feeling very solid that high 80 to 90% of our patients are screened annually using the PHQ-2 and the PHQ-9 screening tools. And this year, this is since July, so it's a fiscal year. We begin our fiscal year in July. We have screened 44,000 patients, which is 90% of our eligible pediatric population, 91% of our eligible family medicine, internal medicine patients. And so the trend continues to increase for this fiscal year. We'll be measuring this through June, and then we'll report out there. And if we take an annualized number, then we should, by all approximations here, exceed both 90,000, be close to 100,000 screenings completed this year. Is it making a difference? This graph here is showing the trend of patients with a positive PHQ-2. So the number of patients who scored higher than 3 on that PHQ-2, of the 440,000 screenings that we've completed since 2019, 37,000 of those patients in our system have had a positive screening. And then of those patients, we can see that there were a positive PHQ-2 of 9 or of greater than 5, 39,000 patients, with roughly 4,600 referrals to psychiatric care of some sort. Locally, what we see in Ithaca is about 7,800 patients with a screening has been completed out of an eligible 8,600, and that's a screening rate of about 88.8%. And we are striving to have that number over 90%. So this is making a difference. We are screening early, we're screening routinely, and we are identifying patients who are at risk. And I think that, if we could quantify how many suicides potentially we avoided, that we interceded with, I don't know what that number looks like, but certainly our reach with this model has identified a large patient population that would otherwise be at significant risk, and then making that follow-up connection. So this past year, realizing the number of referrals that are coming through our system really informed a process internally that we start to make more concentrated investments in recruiting clinicians to Guthrie and to our team that could embed with our primary care physicians to really facilitate a warm handoff for any patient at risk. And it gives me great pleasure to see Dr. Zaff in person tonight. Here's her caregiver spotlight, and I'm sure she's a familiar name to many of you in the room. And I'll toss it to her a little bit to talk about what she's doing at Guthrie and what her role has been since she's joined our organization just a few months back. So, Dr. Zaff.
Thanks, Sean. So hi, everybody. So it has been really nice to be able to be in this position because it is a very new position. So it's been nice to kind of work on some of the things, and I think we're working out and got a good balance going. So my primary role is to provide a short, brief term model of care. I am not the community mental health. I'm not the person that they're going to come to for years. I am the person they're going to see for on average 4 to 6 sessions. I'm getting them skills. I'm getting them stabilized. I'm giving them, some sort of stability, hopefully branching them until they can get into long-term care, knowing that there is such a disparity right now in the amount of care that is available. So my goal is to try to get them tied over until they're able to get into a care system so that they're not without anything.
That's for Janet.
What's that?
Yeah, it was just somebody's not muted.
Okay. And so that's my general model of care is this brief short-term model. On average, I cannot see people weekly. I see people on average once a month. Just because there's one of me and there's lots of people. So because of that, I see people on average once a month. We have a lot of CBT, behavioral interventions, ACT, those kind of things to get them going. In terms of my schedule, I also have frozen time slots. So those frozen time slots are for warm handoffs, or in the moment, this person is in crisis, they need to go somebody. So that's something that's very unique about being able to be integrated, is that I have this protected time where most clinicians do not have that. So I have this protected time where I have the ability to take somebody who is in crisis. So far, I've had that happen twice since August, and both times I was able to de-escalate. We were able to feel better, and that was it. So it's already been quite useful having that space. And I think that continuing to use that is going to be a really beneficial model for care, and making sure that we can minimize hospitalizations that are unnecessary, because a lot of times it's, lack of access. I didn't know what to do. I was in this moment of crisis. I don't like the hotlines, so I go to the emergency room and then I end up hospitalized, which could have been avoided in some circumstances. So it's been really nice to have that option. Otherwise, I am also doing some assessment. So I also am doing some evaluations. I do a lot of ADHD assessment now. I don't do a full neuropsychological assessment, but I do a pared down model that has been discussed with the specialists at NYU. And so we're doing kind of a briefer version of a psychological assessment and evaluation for ADHD to help facilitate our providers in prescribing. So we're doing that, and as well as the depression and anxiety and all of that. The other thing that has been really wonderful that I've always preferred about being integrated is that I communicate almost daily with providers. It is not something where I wait until something is wrong, because we are on the same system. My notes live in the system. They can see my notes. I see their notes. I know everything that's going on with this patient. They know what I'm doing. And it makes it so that I can copy them on my note and say, hey, by the way, we talked about meds today. I don't prescribe, so can you please talk to them next time about this potential medication option? And so that's really helped, I think, as far as facilitating that process, because a lot of times I have people who come to me, we're like, well, I just didn't know what questions to ask in the moment. And we come up with the questions, we address the concerns, we are able to talk through, well, I know that I have this reaction to stimulants, and I have ADHD, but I can't be on a stimulant medication. Oh, well, did you know there's non-stimulant medications? Things like that, where I can have those conversations with people who really, truly have no idea. And so just providing that psychoeducation to bridge that care between the medical and the psychological health aspect. Anything I missed, Sean? Anything in particular?
No, I think that's great. Thank you so much. I think that, so we talk a lot about what we're doing for our patients and that early intervention and screening and identifying patients that are at risk. Post-pandemic, we also don't want to forget that caregivers in of themselves are an at-risk population. And so Carrie's going to highlight for us part of our program, little less formal, but still very important, is taking care of our caregivers. So Carrie would like to talk a little bit more about what we're doing in this space.
So at Guthrie, we consider all employees caregivers, whether they're in housekeeping or front desk or anywhere. We're all working together to help that patient. Guthrie's always had an employee assistance program, but I think in the pandemic, we really realized we needed something really robust to support people that were under so much stress and dealing with so much. So Guthrie created the Thrive Wellbeing Program. It's really a comprehensive emotional well-being and work-life balance program for our caregivers and their families. All components are free and totally confidential. So there's 24/7, 365 counseling with a licensed clinician. There's also, you can meet with a financial counselor to help maybe deal with budgeting or other financial stresses. You can meet with a lawyer to maybe think about your kind of end of life, or thinking about whether you might need to start maybe going into divorce proceedings, things like that. There's even yoga classes, which I know my team really loves. We all kind of roll out our mats and do some yoga over lunch, which is really fun. The other relatively new program that I kind of get excited about, because I also attended it, is the psychological first aid training. So this is a half-day training that Guthrie provides to any caregiver who's interested. And it really just helps you identify other caregivers who might be struggling and gives you kind of some tools and ways to start engaging them and opening a conversation so that they know somebody's there for them and somebody can kind of help them with what they need. And then you get a nice little badge like this, and it just signals to people, okay, that's someone that maybe I can talk to if I need something and I'm struggling. So I think that's been another nice benefit that we've had. But really, we really wanted to thank all of you for inviting us here and hearing a little bit about our journey towards zero suicide and what we're doing to work towards that.
Thank you so much. Does anyone have any questions? Yeah, Jessica.
I have 10 questions, but I'm gonna pare it down to 2. I'm an integrated behavioral health consultant at Northeast Pediatrics. So I think it's awesome that Guthrie is getting into the integrated behavioral health game. Given that not all patients who you all see in Guthrie are in Guthrie for their medical home. I'm just curious about efforts you all are making in terms of connecting throughout the community. For instance, I don't think anyone from Guthrie, unfortunately, was able to attend the last Zero Suicide Steering Committee. I'm also wondering about if you, Dr. Zapp, in particular, are a member of the Collaborative Family Healthcare Association, which is the national leader in this work, or if you are a part or are interested in connecting with myself and my team and the integrated behavioral health team at Cayuga Health System, which have gotten to be fairly robust systems, and we love connecting.
Yeah, short answer is I am not yet, and I would love to be. To give a little bit more background, so not only am I new to Guthrie, but I finished my postdoc at Cornell last year.
Okay.
So I am a newer provider. And so because of that, like I'm still getting integrated in all the things, working on licensing exam, all the fun stuff. So, you know how you know what it's like. So, but I'm looking forward to doing those things. All of my clinical experience throughout my entire education has been in integrated settings. So this is like collaborative care is what I have done for the past 10 years. So I would be highly interested in having more conversations with you, Jessica, about that. And as far as what we're doing, so the one thing I didn't mention is that, so I'm integrated in family medicine. The majority of my referrals come from family medicine or internal medicine. However, I do occasionally get other people throughout Guthrie or people self-refer. So I do occasionally have that filter in as well. But then obviously, just like with anywhere, I already have a wait time. My new patients are booked out to February. So because of that, doctors do communicate with me if they have an urgent concern, and they will reach out to me directly. I've told them, if there's somebody that you're like, they need to be seen sooner, we figure that out. But also we have been working, myself and a couple other providers, on having a lot of resources available and things to be able to help with the referral process and kind of helping facilitate as to the best of our ability for additional resources.
I think that's really, quite honestly, where the community resources are so important. And this is use the term, it's a bit of an elephant burger, right? Like, where do you start? Where do you put your energy and efforts? And we had such a challenging situation just within our own patient population to really take care of and address. And so that's where we opted to start our effort. I certainly think that the zero suicide model, we are moving in that direction more formally. It is a bit of a challenge for an organization of our size to scope that down with only one county that we are working with at the moment, and that being in Tompkins County. So we've put that investment and that energy there. We continue to refine our team, trying to get the inpatient side of Cortland and have more robust representation with the coalition and with the Sophie group. And so I think there is plenty of opportunity for us to continue to move forward and more formally approach the work in this space.
And then my second question is, what are you all doing to facilitate? So part of the PCMH standards is to have follow-up within 7 days of not just an inpatient stay for mental health reasons, but also an emergency department visit for behavioral health concerns. So I'm curious to hear what you all do as a system, both for your internal patients and patients who visit Guthrie, but are serviced by an outside medical home in order to facilitate those 7-day follow-ups.
You want me to take it, Sean?
Yeah, sure.
So there are a couple of things. So a couple of the steps. So one, we have care coordinators that are, as they mentioned, that are integrated to help facilitate that process and help do the follow-up. So if they have the appointment scheduled with their primary and some reason miss it, they're kind of helping with that follow-up process. And then we also have because we have the integrated system, obviously, then we have direct communication. For me personally, sometimes as far as my follow-up care, often they do not come back to me because once they're at that level, I don't feel that I can ethically provide high enough level of care for them because I can't do like a weekly follow-up or things like that afterwards. So usually a lot of my people end up being referred to community mental health or somewhere where they can get the long-term support that I can't provide. But they make sure that they are facilitating that process and that I know that with the inpatient, they do not leave unless they have those appointments scheduled.
So to clarify, if a patient walks into one of your urgent cares for a behavioral health concern, the care coordinators are helping to ensure that they're getting a follow-up with their PCP?
I was speaking more so about the inpatient. So with I don't know as much about the ED because I don't usually work as much with that from the PCP perspective. Sean, can you speak to the ED more?
Yeah, ED, of course, we don't have an emergency room in Tompkins County. The bulk of our ED work is either at PAC or at Cortland, and we do have the inpatient behavioral health units there, so they're plugged into the system from that perspective. Our walk-in care at City Harbor is considered walk-in, not urgent care. So the standard there is not applied with respect to the walk-in. What we do attempt to do is to facilitate follow-up appointments, either using community resources or in a severe situation would be then to transport that patient to Cayuga's ED in an emergency situation where then they would be followed from that organization and from that system. So it does present a challenge. I mean, I don't think anyone here is naive to that opinion or to that circumstance that we are working with a patient population that may be ours and in many cases may not be ours as well.
Thank you.
Well, thank you so much for this presentation. You are all welcome to stay if you're interested in learning anything about the opioid task force. You're also welcome to go. But we really appreciate you coming and sharing this information with us.
Thank you so much for having us. It's been a pleasure.
Thanks, Sean.
So we have dual presentations tonight. So next we're going to be hearing from Ross Milne regarding the LGU opioid settlement program design update.
Great. I'm just gonna share my screen real quick. Cool. Okay. Yeah, my name is Ross Milne. I am new to Tompkins County Whole Health. I just joined as a public health graduate fellow in September, and I moved here from Seattle, Washington. So excited to be here. And one of the two projects that I'm working on is trying to look into the evidence base and do some program design for the what we're calling an emergency housing and services program that I think we've all decided we should direct our LGU opioid settlement funds towards. And so I'll get into, a little bit about where the funding currently stands, planning process, just a quick refresher on how we got here, and then, into the program objectives, design, and where we're at and what our next steps are. So into the good stuff. Sorry for this small text. This is just the most recent update I could find on the LGU opioid dollars that Tompkins County and the city of Ithaca will be receiving. As you can see, this is a sort of long-term source of funding. It goes, I think, for the next 16 years in varying amounts. And those amounts are definitely fluid. We've gotten updates as recently as this week to some of them as new opioid settlements are settled, I suppose. And you can also see, I think, that the bulk of the money, and this is in thousands here, the bulk of the money comes up front in 2022 through 2024, and then kind of tapers over time. That might change, but this is what we know now. The city of Ithaca and Tompkins County, I think, are in the process of establishing an agreement to combine their funds. And so I've included kind of here sort of what we expect for 2022 through 2024, about in total 1.37 million between the two jurisdictions. And then there is an option with this funding to take out up to 15% for administrative costs. And I can talk about that later, but more about coordinating from our end with the agency or organization that we hope to contract with. And then as we look forward, we're wondering, can we extend this? Right now, we're thinking about a 3-year pilot program, but if we want to make it a little bit more sustainable, should we potentially hold back some money these early years to offset some of the costs in another cycle? And you can see, this is all rough budget, but this is kind of what we've thought. We might have about $1 million available for the first 3 years. And then have, include some of that in the additional 3 years there. And there are some stipulations on this money. It can be spent over multiple years. It can't be used for capital projects. Because Ithaca is contributing about 10%, we've kind of thought maybe we'll hold back 25% for the city of Ithaca, with the understanding that most of the people that are served by this program will probably be from Ithaca. And I said up to 15% can be used for administrative costs. And OASIS, the administering body, has said that since we have a local services plan in place, the use of these funds should probably be in alignment with the objectives for that. And so I think that's what happened here before my time, was a crosswalk of the local services plan with the approved uses and funding priority areas from OASIS. And you can see on the left that I'm not going to get into this, but there were several objectives across housing, cross-system services, non-clinical supports that were identified as kind of aligning well with approved uses, for creating housing to support people in treatment and recovery, providing funding for peer support specialists, and more broadly kind of supporting the general infrastructure around people who might have opioid use or substance use disorders and co-occurring mental health conditions. So where I came in, I think you all had decided that this money would be going towards an emergency housing, intensive support, and streamlined coordination program for helping people to stabilize when they've been living in a cycle of crisis, potentially disconnected from care, and experiencing or having a history of opioid use or substance use disorders and mental health conditions. To really bridge that gap between the emergency services that they've been kind of relying on to meet their basic needs, like going to the emergency department, and more community-based care and permanent supportive housing. And some of the objectives that we hope, this program will help contribute to are improved housing stability and retention for those people, improving overall health and well-being through improved access to the social determinants of health, and then reducing the need for crisis response services to meet basic needs and potentially frequency of interactions with law enforcement. So when I first started, one of the documents I got kind of laid out assumptions of the 3 things that are needed to support people who are living in a chronic state of crisis. And those were a place to live, someone to help, and the right support at the right time. And what I've been kind of working on over the last several months is looking into the evidence base, talking to local experts. I'm new here, so I'm really relying on people who have been doing this work for a long time, and to what kind of the best practices would be for each one of those components. And what kind of identified at this point is, for a place to live, we want to look at something like low barrier emergency housing. We've got some permanent supportive housing here. I think we're going to get more, but what we're kind of missing is sort of that link between. It can take a long time to go through the SPOA process or just to get permanent supportive housing. So how can we support people in the moment? And then intensive case management and peer support. Housing First is a great model for a lot of things, and really kind of one of the keys to that is that it's housing paired with really intensive support. And that can produce positive health outcomes. It can produce housing stability, reductions in substance use and kind of psychological symptoms. But you really do need that intensive support. And the way that we think it could work is through intensive case management and peer support specialists. And then finally, getting people access to the services they need when they need them, and when they want them too. And so we've got some processes we're hoping to implement that will help out with that. Just to get into like how we kind of see this playing out in the program design, pulling from a lot of Housing First principles while acknowledging that this is not permanent supportive housing. We need really rapid access upon intake into the program. We don't want to miss that kind of window when somebody comes looking for housing, and potentially can't get in, by the time we've gone through administrative hurdles and things like that. Also, this population does have serious substance use and mental health co-occurring disorders, and we need to create sort of an environment where those can be effectively managed, allowing people to still have their sort of freedom to have their own goals and desires. And so we're not having any sobriety requirements and making treatment and services voluntary. There would be an expectation to meet with your peer support specialists and your case manager regularly, hopefully multiple times per week, at least up front. But that would be kind of the main requirement. Housing First has also shown that like client preference on housing like type and unit, and having roommates is really important as well. So we hope that whoever takes on this, this creates proposals for this, will propose a variety of housing types to meet people's individual needs. And then occupancy agreements around kind of safety in the units. And then what we're really looking at is a 6 to 12 month housing duration, hoping to kind of do an average of 9 months, but that'll be dependent on people's individual housing needs. The Someone to Help component, as I mentioned, is going to be based around intensive case management and peer support specialists. And as I said, that high intensity support, especially up front, we're thinking 2 to 3 kind of contacts per week, that could taper over time, and in alignment with best practices for intensive case management, keeping this at less than 10 clients per case manager, which means that it will be a small program for whoever takes this on. And the goal will be to kind of create with the clients individualized person-centered care plans. And to do that, we're going to need the case managers and the peer support specialists to have, adequate training and assertive engagement, motivational interviewing, kind of best practices there. And the peer support specialist role, for a lot of people, navigating whatever services they're going to engage with can take a lot of paperwork and be challenging to get to those appointments. And so the peer support specialist is really intended to kind of take some of that administrative burden off. And then finally, some safety planning and some form of 24/7 crisis support, whether that's contracting with 988 or having somebody available by phone during evening hours. And then to get people the right support at the right time, we are asking that people propose, or organizations propose, a program coordinator position to kind of liaise with us, as well as the crisis intervention team that will be kind of referring people to this program. And then overseeing, its implementation overall. We're also going to need to figure out some data and information sharing policies and procedures. And I'll get more into that in a second, but we're looking at coordinated entry as a potential model, using HMIS for tracking client service engagement, and then multi-party releases of information to improve coordination across service providers. And then finally, kind of that rapid piece is we're hoping to create some mechanisms by which people in this program can get really quick access to services. And that would be through MOUs with service providers for things like substance use disorder recovery and treatment, medical assessment, and healthcare. One of the cool things is Ithaca College, I think, is going to be providing TBI assessments and then other mental health assessments, potentially could help people get into assertive community treatment or other programs. Okay, so how do we get people into this program? This is where we're still kind of working things out. This is a referral process. The way that we initially kind of thought things would work would be the crisis intervention team members would be bringing together kind of, these are the people that we're seeing at the ED. These are the people that IPD is potentially, picking up. How can we identify who needs this most? And working with Human Services Coalition, other community partners, we kind of settled a bit on the coordinated entry process because it's already here. It's a evidence-based tool that allows us to equitably prioritize people for this program. It has these kind of three components here: pre-screening questionnaire, vulnerability index, and multi-party release for HMIS already kind of integrated into it. The one thing that is kind of a limitation about this is that those first two tools are self-report. And so we are potentially assessing whether or not we need to have an additional step to really determine the clinical need for people who might come into this program. And so this is still in the works, but kind of the flow that we see is, our partners will make a referral to coordinated entry. They'll do their standard assessment of program eligibility, evidence-based prioritization, and then they might make a referral back to us.
I think there's some work going on.
So yeah, they might make referrals back to the crisis intervention team or potentially a coordinator position that we have or we might have. And then that could allow kind of clinical experts to bring in their experience into determining who would be a good fit for this program. So we're still working on that. And we're still working on a few other things. We're going to wrap first draft of the RFP and our and evaluation criteria for proposals that come in. We just had a meeting last week with a bunch of community partners and experts and have some feedback that we're incorporating into that. But hopefully we can get that submitted to our partners for review, purchasing and legal for their review in December, early January, and then post that RFP in January. Takes about a month for those to run. And so if all that goes to plan, we could begin implementing this sometime in spring. I always want to budget more time than less, but I'm hopeful. And so that's it for me. And then while we're doing that RFP process, we need to kind of iron out those MOUs with service providers and potentially policies for the CIT work group when they're reviewing referrals for this program. And then develop a plan for monitoring and evaluations. And I'm working on those.
Great.
That's it.
Thank you. And of course, everyone, I'm sure, realizes this, but I misspoke and said opioid task force, and this is the opioid settlement dollars that are funneled through the LGU, not the task force. So I just wanted to correct myself for the record. Well, thank you very much. Does anyone have any questions? Yes, Jessica.
Can you stop sharing so we can see the others?
For the potential Ithaca College MOU, is that on their college health medical side or CAP side or totally separate and through the college?
I defer to Harmony on that.
We're just really in some early steps and conversation about that.
And then it seems like a really quick turnaround between posting the RFP and reviewing and evaluating the submitted proposals. I presume people who, like organizations who might be interested in RFPs are like aware of this. It just
So
seems
the
like,
county has a process when there's RFPs for making notifications,
Yeah.
and then we can also do targeted notifications once it's out. So those two things will happen. It'll get posted. It will go out to the places that RFPs generally go to, and then we will make notification to local and regional entities that we think might be interested to participate, to let them know it's out there.
do you think the 1 month turnaround is gonna be fine?
We're hopeful. I
Yeah.
mean, we want to move as quickly as we can. Generally speaking, usually 30 days is about what's offered for
Okay.
RFPs.
Great. Thank you.
Any other questions? Any questions online? Did your phone go up?
I'm a little confused about the process. By the way, welcome to Tompkins County. Some similar weather.
Yeah. I know, yes.
Well, sports later.
Yeah.
Getting this report, shows me you're working for the county,
Mhm.
right? And you said you just moved here. So this position was created for the purpose of dealing with the opioid money coming to our city and county?
So Ross is a public health fellow. We have 9 public health fellows working in the department right now on various projects. When we had a vacant position, I consulted with Harmony on what projects were out there that would help her if we could use a public health fellow for. And that's when we identified the creation of this RFP to take it kind of off of Harmony's plate. She's got a lot of other things to do. Ross and his background and expertise kind of lined up with this as we were interviewing him for other public health fellow projects. And so it just kind of came together. And so we're leveraging those resources to help us move this forward.
So it's great. I mean, I love it. It's like you just fit in right at the right time. Like,
Yeah. Good situation.
so you're not gonna be part of the first million or any of the funding. This is just something that goes on, so you're in a position. Okay, and we'll probably know by, I think, April, when some of these programs may start, or this particular one.
That's what I hope, yeah.
That's our hope, yeah.
Jan, did you have a question?
Oh, I just wondered, maybe I'm just spacing out, but what does CIT stand for?
Yeah, sorry, it's the Crisis Intervention Team, which was, I think, established as part of sequential interest-only mapping.
Cuda Medical Center,
Yeah.
their behavioral services unit established a crisis intervention team. It's confusing because it's the same term that they use for law enforcement training that is designed to help law enforcement officers understand mental health crisis needs. But it was modeled after, I think, a hospital in Seneca County, and the idea is a number of agencies come together on a monthly basis and talk about any kinds of situations that individuals that they're really concerned about in the community. They have a contract so that they can talk with each other. And so sometimes what we see is there's a lot of concern in the community, but not a lot of resources available. This is a really significant gap. It looks like a lot of money for a small amount of people, but it's really, this program is being designed for those people that people have a lot of worry about because they're very, very vulnerable and their needs are right in that spot where maybe they don't need hospitalization, but an outreach worker isn't sufficient, right? So it's really designed to make sure we're getting those people the resources they need. And many of the people that go to that monthly meeting, that's who they're concerned about. And maybe like the shelter, law enforcement, and they're people that they're all maybe touching the lives of these individuals, but it's not effective.
Thank you. Any other questions?
I just would like to just mention the city again. Deb is with us, and the city got their own allocation of resources, and we're very appreciative that they are interested in partnering with us. You can see their dollar value isn't huge, so on their own, the impact probably wouldn't have been as significant, but putting it all together really allows us to build this long-term plan around something. And the reality is, many, as Ross alluded to, many of the people being served are going to be city residents anyway. So I think it's just important to point out that collaborative approach and our, just offer our appreciation to Deb and the city for their willingness to work with us as we move this project forward.
Thanks, Frank. And Harmony.
Thank you. All right. So moving on to commissioners' report.
Sure. So you got ahead of me earlier. At least this is your last meeting with us. And we wanted to take a moment just to recognize that and all of your years of service, both to the board, the subcommittees, and as chair, and offer you this certificate of appreciation.
Thank you very
Yes.
much.
And Harmony has, there's the poinsettia for you to take.
Beautiful.
Will help get a cart of some sort to get it downstairs. They are working on refreshments as we speak, but we can kind of continue there's just a couple of other things to do, but I just wanted to take the opportunity to thank you publicly for your service to the board, and we very much appreciate those many, many years that you've given. You've always been a voice of reason here, and the expertise that you bring, both as a community member, but also as, in your professional life has been invaluable to us in this board. So thank you.
Well, thank you so much. And again, it's just been wonderful working with all of you, and I will miss it. But thank you so much.
Sure.
And for our guests, you picked the right night to stay. To get treats.
So while they're working on treats, just one other thing, the construction at Brown Road has gone, I shouldn't say it, it's going good. I don't want to jinx it because it's not done yet. But the space, the actual soon-to-be mental health license space is complete. Except for some new carpeting that needs to be laid next week. And my thought was perhaps we could have our next CSB meeting at our Brown Road facility. So that way you all could then see the new space. So if that's, of interest for folks, we can certainly get that coordinated. So folks can see what's going on up there. I expect by then it'll be fully complete. So you'll get to see it in all its glory.
What are the people will want to see? Yeah, I was just gonna joke and say, will there be noises like we just?
No, hopefully there won't be any construction. This building is getting new HVAC, so which is still what's going on, and the 5th floor was last. And I think that's where they are, is they're on the 5th floor doing the HVAC work, right?
It sounded like some duct work going.
Yeah, doing some tin cutting and pipes. That's all that I had.
Okay, any questions for Frank?
Can I ask, not super related question, but a question I have anyway? So I know we had we had Tammy Baker here recently to talk about the housing, various initiatives, and I have a hard time wrapping my mind around all of them. I was curious if we have planned to have Liddy Barger here to speak with us. My sense is that there were some differences.
She's been here before.
Yeah. Okay, never mind.
And she's been very active in our projects.
Yes, my sense is that she had, and the HSC perhaps had different takes on things compared with Tammy Baker. So I'm glad that Liddy already got a chance to speak here.
Actually, since you brought up Tammy Baker's name, Frank, any thoughts about her replacement or?
It's a good question. I don't know the answer to that. There is, I believe now with 2023 being gone, there's 2 years of funding left from the legislature for that position. So I would assume the county is going to look to refill it, but I don't know that for certain. What their approach is going to be, but I can certainly ask county administration, let you guys know.
Are the services still happening? that she provided or in her?
Well, the whole purpose of her position was really to provide recommendations to the legislature based on the homelessness issue. And that report that she presented to you all at the last meeting, I think was her first foray into that. So there were some recommendations in that report that she had provided to the legislature, I think the month before, with that. So to that extent, some of the work was completed.
Yeah.
I think, honestly, I'm not sure that the legislature had a fully fleshed out vision for what that position would be over the full 3 years. But I can tell you that there are active conversations going on around addressing both the encampments and the homelessness issue from the county perspective, trying to figure out, how do we do, that immediate emergency sheltering piece more effectively than we're currently doing. And so there's more active talks going on about that than I have seen in my 12 years that I've been here. So I think I'm heartened that they are going that deep and are actually looking at some pretty extensive, what would be pretty extensive and expensive solutions that solution, we're not solving it, but that would create a better, more effective approach to dealing with emergency housing. So obviously, those things, some of those things are working behind the scenes, so there's not a lot of information to be shared publicly at this point. But I would just offer that this is the most heartened I've been on the county's approach to this, as long as I've been working on this issue for the county. So hopefully we'll be hearing something relatively soon about an approach that will improve things.
Frank?
There's coffee if anyone wants any. Put your hand up, I'll get it for you.
So our next agenda item is an executive session, but I'm not gonna rush anybody. If you finish your cake before we kick you.
I don't think we have two pieces left, so.
No, we don't. That's right. You said
You're just
no.
doing this, you don't need an executive.
Yeah, oh, so relax and enjoy.
If you want me to mention just a couple of things, Mary, who's the chair of our nominating committee, and Stu and I are on it. She and all three of us would like it if community service board members would really consider joining the substance use subcommittee. That particular committee needs 2 members of the board on it, and we don't currently have that. So that's pretty important, and we like to see people, take a turn at one of the subcommittees. That's really helpful. The other thing she had on here was Larry's reappointment for CSB and mental health, but that just happens, right? That's not something we have to vote on because it's reappointment. Is that correct?
Well, usually, we want a recommendation for reappointment from the group.
Okay, so then we would have to go into executive.
Did we already do that?
No, not yet.
Because we just got Larry's application. Yeah, you can go into executive discussion to discuss it if you feel like you need to, or you can just make a motion to do it.
Would anyone like to make a motion to go into executive session, or do you feel you know enough at this time?
Okay, so all in favor of recommending Larry to be reappointed in his various roles?
Yeah, that would be to our board and also to the mental health subcommittee.
Need a mover and
Oh, I'm sorry, can someone move? Thank you, and someone second. Okay, all in favor of recommending Larry?
Thank you, just for the minutes.
Thank you.
And the last thing is the slate, and the slate is, at this time, it's myself as chair, Jan Lynch, and vice chair Sheila McHenry right here. So there's 30 days for people to think about that, and then we vote in January.
Yep, the bylaws require a 30-day notice for the slate, so this is the notice. Anyone that is interested that might want to run for one of those 2 positions, the opportunity is still there, and a nomination could be made at the next meeting.
That was it from the nominating committee.
Well, my 2 cents is typically we have the vice chair in line to be the chair 2 years down the road. I don't believe that's going to be the case here. So again, urging board members to perhaps think about their role here on 2 levels. President in 2 years, feeling comfortable to take on that role, as well as reiterating the substance use subcommittee. For my years of being on it, it's been fascinating to have some of the ideas come to fruition from drug court, kind of started the ideas in that committee to where it is now, to the latest with, well, what do we do with this opioid money? I mean, a lot of people get involved in that, and folks on the committee had a lot of influence on deciding that. So we can use some of your help to get that committee enriched with more of your ideas.
If I could make a pitch for it as well, the legislature has been asking about creating an overdose task force. And I've been trying to not create a new one, but rather say we have a substance use subcommittee that works with the community services board and that they are reinvigorated and interested in those types of issues. So I think there's going to be more coming direction wise from the legislature about some hopes from the substance use subcommittee. So if overdose prevention and our efforts around that are of interest to you, this would be a great time to get involved.
If anyone has questions about that, you're welcome to email any of the board members or Frank or Harmony, the board members that have been on for a while that could maybe answer the questions as well. Okay, anything else from nominating committee? No, that was it. Okay, so there's nothing else. We can adjourn. Motion.
Thank you.
We should do adjourn.
Thank you guys so much for coming.
Thanks for letting us. Really
Oh, yeah. Good luck.
Thank you.
And if there's anything we can do to help.
Yeah.
Yeah, it's a lot, so figure it all out, yeah.
Actions and figure out.
Yeah.
Everybody's time.
During the day. And if you're ever just looking for, you know, who should I talk to, you can always reach out to us and we'll try to get you. All right, sounds good.
No, I know.